is below, so you're only getting 65% registration with a 10% reduction in volume, and you can see where on the bladder the actual surface is not being registered. This is actually used in our clinic for evaluating surface changes of a patient for potential replanning needs, adaptive replanning. The patient may lose a significant amount of weight, say a GI patient or a GU patient loses a significant amount of weight. We can see that during setup, use this to give to the physician for his weekly management, and then that can trigger either a new CT or a new plan of reevaluation, a scaling of the modern units, whatever you might do in your centers. We use this on head and necks for weight loss. We use this on breast patients who have swelling. We can, in real time, monitor this patient's anatomy. We had a GYN case where she gained 15 pounds over a weekend and actually ended up being a significant underlying condition that was fluid retention. Monday wasn't necessarily her on-treat day, but we caught it during setup. We gave this image to the physician and said she has extreme distension in her abdomen. We think you should probably see her. She has no signs of complaints. She's not, verbalized that to us, but we saw this on the system, and we passed her off to the physician. The physician passed her off to the med-onc, who found an underlying condition. She was admitted and actually ended up potentially saving her life. And so this tool is now more than just a setup tool. It's more than just a motion management tool. It is a full clinical management tool for our patients. So if you go to the next slide, slide 13, another example of that is plan-specific tolerances. What you see here on the left is a graph of a SRS patient-specific QA on an anthropomorphic phantom, and on the right is the actual trace of that patient's delivery. What this allows us to do, you can see there's some interesting correlations between the phantom plan and the patient-specific delivery in blue there on the right. The entire vertical axis on these graphs is the 1 millimeter SRS tolerance, and you can see on the patient-specific QA on the left there, the orange, that in the last two couch angles, it looks like that the tolerance, you're getting close to the 1 millimeter tolerance. You're right around 0.7 of a millimeter. But we know that this phantom's not moving. This is something we're doing before the patient ever shows up. And so we can kind of predict what's going to happen with this patient. If the patient is 100% compliant, the best we can assume is 7 millimeters or 0.7 of a millimeter at those two couch angles. And that's good to know, because one of the correlations I always tease my therapist with is that it correlates to the mood of the therapist within the control room during delivery. As you approach that 1 millimeter tolerance, the amount of concern on their face goes up. But if you know ahead of time that these features that correlate between the two traces are real, and that they are a characteristic of the system and not that your patient is moving, you can address those proactively rather than retrospectively just evaluate them and say, what happened here? Did the patient move? So we can do a 1D feature-based registration of those two signals. We can see that in those last two couch angles, if you look to the right there on slide number 14, the next slide, that the patient's ROI, which is essentially the face for an SRS patient, is essentially walking off the field of view. You have a round optical lens projecting onto a rectangular sensor, so you have some truncating of the information at the edge of the sensor, and so that contributes to a little bit of an inaccuracy around the 0.7 of a millimeter range at this point, because you're operating right at the extreme edge of the field of view of the system. You also have couch walkout at this position, and so you're beginning to tease out what's actually happening with your patient before your patient even arrives. And so now your quality management program is proactively identifying potential issues during treatment, and you can go back to treatment planning and you can say, okay, well, we need to avoid these two couch angles because one, either we have couch walkout at this issue, or we're actually walking off the edge of the sensor, and you can do that ahead of time before the patient comes in, and then you don't see this anomaly during the patient treatment, and you don't have to worry about recone beam CTing the patient, re-imaging the patient, moving the couch back to zero. Is it okay? Is it not okay? Which leads to a much more efficient, more effective treatment, because you're not guessing at the time of delivery. You've already proactively QA'd the system. So on the next slide, on slide 15, an example of this, you can see on the left here, that's the SRS QA that we did on an anthropomorphic phantom about 4 years ago. Here's a very similar SRS, same couch angles, same gantry angles for the most part. On the right, you can see they're very similar. You can check the calibration of your system over many, many months by looking at the stability of this. We use templates for our SRS. You can also tease out information about characteristics that are in one system. If you click through, you'll see circles on a number of features in the left that aren't in the right. The patient on the left was actually receiving their 9th SRS at our institution. So we were using very non-standard gantry angles and couch angles because we were trying to avoid previously treated areas. You don't see that in the right signal in the red on slide 15 because we were using our standard gantry and couch positions. And so we can start to look at, okay, well, where are the mechanical inaccuracies in our system? Do we need to avoid these if we're trying to treat previously treated areas? Do we need to avoid certain gantry and couch positions because either obstruction characteristics are too great, or maybe that's not ideal for our LINAC, and maybe our LINAC has a little bit too much couch walkout at certain positions. And so you can go back and correct the plan proactively and not have to deal with that on the patient at the time of delivery, because you're now not finding it during delivery, you're finding it ahead of time. So next slide, number 16. What does all this truly mean? As a physicist, we get into the numbers and the data and the graphs, but truly what this means is patient satisfaction and patient safety and the quality of our treatments. For our patients, that means tattoo-less based treatments, which means shorter, more effective treatment times, shorter, more efficient simulation times. Our simulations in our centers, because we're not doing tattoos, are around 5 to 10 minutes, like I said, and our treatment times are anywhere from 10 to 15 minutes. Many clinics, that's not a concern. I know I talked to some at Astro where they were not overly concerned about treatment times. They said we stay open as long as we need. But what that means is you're more efficient during those hours that you are operating. And so you can get either more patients on the machine, or you can do a much more quality-driven approach to your treatments. So you know going into the treatment that you're not going to be troubleshooting at the time of treatment. You've already done all of this by basically looking at the system through the SGRT eyes of an observer-based pattern. And so what that means is essentially for us, without using tattoos, we're getting much more accurate setups, which leads to far less imaging, less imaging dose, less time on the machine to image and try to correct posture, lower dose to critical structures using things like BIBH for SBRT and breast, and not just a breast technology, but also moving it into liver SBRT and pancreatic SBRT. And we're constantly monitoring our patients before imaging for setup to correct their posture, during imaging to make sure they're not moving and invalidating that cone beam CT shift, and then after imaging to make sure they're not moving away from the approved treatment position. And then for us, especially here in the States, we have the ACR accreditation, the Joint Commission accreditation. We also have the Astro Apex accreditation, which I'm sure many of you heard of. All of those things have a component of continuing process quality improvement. The SGRT system being integrated into our treatment fashion the way we have it just lends itself to a very efficient way to keep all of these accreditation requirements in place, because you are continually improving your quality. So SGRT, as we've seen throughout this presentation, is essentially a whole body technology. There's really nothing that we have run into that SGRT does not improve the quality of and improve the efficiency of. So we're talking extremities, but also liver and lung SBRT, lymphoma cases in the mediastinum, which we'll see in a moment, SRS of the brain, breast cases, GI, GU, spine SBRT, head and neck cancers. We're really finding that SGRT has a niche in every one of these treatment areas, and is one of the only technologies that has such a wide applicability in that case. A lot of other technology, you think of X-ray based technologies, something like BrainLab. If you don't have a lot of stable bony anatomy, you're basically relying on a virtual isocenter, essentially, where there's stable anatomy is, and assuming that there's a correlation between the two areas. SGRT really can kind of address you where you're at. And so that's a nice feature of AlignRT and the SGRT, and even Gate CT and the CT suites as well. So some examples of that, more clinically relevant examples. Obviously, we talked about deep inspiration breast. It's very easy to line this patient, have them breathe into the breath hold surface, get them within their 3 millimeter tolerance at our institution, take a port film. You can see here, this is a live port film that we snapped an image of after breath hold of this patient. You can see that the port films line up very well. This allows us to do breath hold every day, but only rely on weekly imaging. And the only time we would go away from weekly imaging is if we started to see some discrepancy either in a weekly port, or if they started having difficulty reaching their breath hold surface. Say they have hay fever or a cold or some congestion, and they're finding it difficult to get there. We might have to increase our imaging to see what that's actually doing to the internal heart block. Another place that excels greatly is in lung cases. In this case, we have a lung ROI. We're breathing the patient into position, so they're within our 3 millimeter tolerance or 2 millimeter tolerance for SBRT lung. We then would do a cone beam CT. We then align that cone beam CT to the internal targets. You can see by aligning to the patient to the ROI, in this case the limited view we have here without being able to scroll in 3D on slide 21, that the lung patient is in a very good posture. The curvature of the T-spine, the C-spine, everything is lining up. We've corrected that posture ahead of time with Align RT, and we're now looking at internal anatomy fit. And so we do a quick registration on our cone beam CT. Moving to the next slide, on slide 22, that now allows us to do something unique with SGRT. This is something that you can do with SGRT that you can't really do with other things. We've aligned this patient with a cone beam CT on slide 22. On the right-hand side, we take what's called a gated capture. So we take a capture of the patient during the breath cycle, so you can see the full breath cycle, and you pick a mid-phase for that cycle. We use a 2 millimeter gating window for our SBRTs, so we set the tolerances to 2 millimeter on that gated capture and turn on gating, and we do what we call set it and forget it. Essentially, the SGRT systems is our eyes in the skies. It's going to gate if there's any gross positional change of this patient, if their breathing takes them out of tolerance, any of that will be gated by the SGRT system. And then we couple that with, on the left, you see a triggered image. On the left, the triggered image is basically a KV image. We can turn on any projection from any angle of our ITV, PTV expansion. And as we go around this patient, we can look at that ITV, PTV expansion, and if for any reason the internal anatomy changes for any reason, but the external anatomy doesn't, we can then gate manually on that as well. So we're looking at a very CyberKnife-esque type of thing where you have an internal and external reference throughout the entire course of treatment. So the clinicians, the physicists, and the doctors can be looking at the internal anatomy where the contours were drawn and the plan intent is maybe an isodose line that you turn to a contour, while the SGRT system is your external eyes in the sky, making sure that your patient is staying within the 2 millimeter tolerance, not moving, not adjusting after your cone beam CT. Where this really, really excels, we find in our institution, is for prostate SBRT. We don't see a lot of lung tumors move unexpectedly during treatment, but on a prostate, if you have gas in the rectum or gas passing through the rectum, we do the same process. We'll basically set the patient up to their external anatomy on slide 23. We do a cone beam CT, we take a gated capture, we set our 2 millimeter tolerances, but then on the triggered image, we've also contoured 2 millimeter spheres around each of the fiducials. So we have gold implanted fiducials. Our tolerance is 2 millimeters, so we put a 2 millimeter sphere around each fiducial. We typically will place isocenter in the central fiducial, so the crosshairs here in blue are right inside that fiducial. And so as we're delivering our VMAT rapid arc delivery of our treatment, we're actually watching the seeds or the fiducials during the delivery, and if they ever migrate outside of those 2 millimeter spheres, we know we're beyond our 2 millimeter tolerance. If the patient is to move or adjust or anything externally, the Align RT system gates the beam, turns the beam off immediately. So we don't have to have our attention focused on there. We instead have our attention focused on the internal anatomy, and in some cases we've seen, a gas bubble pass through the rectum, and the prostate will shift posterior or shift to the left real quick, and you can immediately intervene in that SBRT prostate while not having to worry about, did I see him move? Did the Align RT see him move? You're focusing more on what's clinically relevant during the delivery and letting Align RT make sure that the patient's not moving or adjusting. So moving on to slide 14, this is another place where surface-guided radiation therapy excels. The Align RT product allows you to have multiple ROIs. In this case, this is a GI case, or a GYN case, I apologize, that has a full periaortic trunk, again on slide 24. And in this case, we have 60 couches, but 60 couches do not correct for all of your sins of setup. What you really want is to correct the patient's posture before you use the SGRT couch, because how many times have we done an image or a cone beam CT and you only have partial portion of these large fields that you're looking at, and you're trying to split the difference between the paraortics and the pelvic fields because the pitch between the pelvis and the paraortics is not correct. The IGRT couch and the 60 couches cannot correct that posture problem. All they can do is move that problem in 6D, but they move it as a rigid body. And so SGRT allows you to get the posture correct by, first on slide 24, having an upper ROI that frames out the paraortics, but avoids the fleshy abdomen that you can see there in green that's moving with breath. You get a very nice stable signal by having a good ROI. Then moving to slide 25, you see a lower ROI that looks at the pelvis and the size of the patient, and that allows us to adjust the pitch of her pelvis, also avoiding the fleshy abdomen to avoid noisy deltas. And then once you have that done, you go in and you do your cone beam CT, you take a look at it, and now you can move the patient as a rigid body and you're not splitting the differences. You don't have to open up your PTV margins because there's going to be some pitch problems. Moving on to slide 26, you can also use SGRT to address, at least in our institution, some patients have modesty issues where they really want to be covered, but this is again a service-based technology. So in this case, this young man is being treated by 2 young therapists, both female, was really concerned about modesty, requested that his shirt be pulled down as close as possible to the treatment area, and the blankets be pulled up on his thighs as far as they could. With the photorealistic display, we can take a simple reference image, draw an ROI that avoids all of the other cover as far as whether it be his shirt or his blankets, and it allows us to set up the patient very accurately while still addressing some of the modesty concerns that he had. Slide 27, this is another extreme posture example. This patient is a lymphoma patient that goes just under her ear, down through her neck, and then down into the axilla. She has a frozen right shoulder, a fused spine, and a number of other issues going on. She was in a lot of pain. In these cases, you can see on slide 27 there, we have a large ROI that kind of covers the chest and the affected shoulder going down into the axilla. That is our starting ROI. If you go to slide 28, we basically will align this ROI in real time using the cameras to within about 3 millimeters, try to get her posture as good as we can with a single ROI. But we know the shoulder, the neck, the chin, the arm are all moving independently of one another. And how many times have we had to go in and out or have therapists go in and out and take multiple films to get the arm in the right position, the chin in the right position, the neck in the right position, because we're treating this large VMAT lymphoma down through the neck and into the axilla, and everything needs to be in the right orientation. So if you move to slide 29, next slide, you can put an ROI in the shoulder. After you get gross positioning with the large ROI, you can then go in and move the shoulder to the right position. This is all happening in real time without leaving the room. Next slide, on slide 30, you can then turn on an ROI on the arm. You can then get the pitch of the arm away from the body correct, so you're exposing the axilla in the same way and keeping the lymph nodes in the same orientation. And then next slide, once all of this is done in the real-time positioning and the posture correction is done through the SGRT system, you take a single KV image, and you can see on the right-hand side there that the KV image through the treatment area, it did need to be adjusted by, it looks like 3 millimeters there, but the posture of the chin, the neck, the shoulder, and essentially the rib cage is all correct, and this is one image. You've now done what you would normally do in 10 to 15 minutes worth of in and out of the room with imaging in a matter of about 1 to 2 minutes. And then you can also see, just as a matter of illustration, she had a frozen contralateral shoulder. If you look at the left lateral aspect of that right image on slide 31, you can see that the contralateral shoulder, due to the clavicular pitch displacement, you can see that it's not in line, but it's also not in the treatment field. And so we're focusing mostly on the posture throughout the treatment field, and while the contralateral shoulder is frozen, we're not allowing that posture to affect the treatment area. So it's a very good tool for, not only setting up your patients, monitoring your patients, but it's also a complement to what your already existing IGRT technologies require, but where they kind of fall flat. IGRT, again, moves things in a rigid fashion. It doesn't account for these pliable posture-based setups that really are patient-specific, especially patients who are in pain, and a lot of our patients have bone mets and those types of things. And so you can address those posture-type issues very easily and still be using your SGRT systems, your IGRT systems to do what they do best in aligning to the bony anatomy, but using your SGRT to get that bony anatomy in the right postural setup before it starts. And so, next slide. Kind of in conclusion, SGRT is changing how we do radiation oncology at our centers in multiple fronts of radiation oncology. We try to harness the information it provides to more effectively treat a wide array of body sites more effectively and more efficiently. That helps our patients who are in pain, that helps our patients who struggle, who may not end up being a candidate for radiation oncology any other way. We can address some of those challenges with SGRT. Again, we're on slide 32. It also enables us to objectively review, then improve our current treatment process through its observer-based nature. So it's always our eyes in the sky. It's telling us how we're doing end to end, and it allows us to do that ongoing performance evaluation, constantly adapting how we do things, constantly addressing any immobilization issues proactively before the patient experiences the issue. We can identify it, and then develop more informed planning margins. This is a big one for us as far as seeing how we're doing and not just relying on planning margins that we calculated at the time of commissioning, but actually relying on planning margins that relate to not only the ability of the equipment, but the ability of the staff as well. It allows us to really address a global view of radiation oncology end to end, rather than just saying, oh, well, a physicist measured this and this is what he calculated as my margins. It really takes a global view of uncertainty for each and every patient individually and allows you to address it in real time or ahead of time, which is most important. And then it helps us to minimize the impact of treatment on our patients. Number one, most important to us, we're trying to minimally impact our patients' lives. They do have to come many times, oftentimes for treatment, many days in a row, making that quick and efficient so we're impacting their lives in a minimal way, increasing their quality of life, while still maintaining a safety of their treatment and doing that on an everyday basis. Every single fraction is looked at, evaluated, and processed, and made sure that if we can do better, we are doing better each and every day. And so with that, I say thank you. I'll take any questions. That should be my last slide. I apologize for the lack of saying next slide. This is the first time I've done it this way. So if there's any questions, I'd be happy to answer any questions, but I'll pass it off to whoever the moderator would be.
Thank you, Mike. And since we are running short of time, we can have one question from the floor, please. Yeah, please. Yeah, yeah.
You start. So, Mike, an excellent talk. I have two questions. One is, do you recommend this system as a stand-alone system, replacing conventional image guidance tools such as CBCTs and other things? That is question number one. Do you recommend it as a stand-alone tool which has already replaced or is going to replace the conventional tools such as CT or CBCT on board? Question number two is the fact that you are forced not to use the regular immobilization devices such as ORFETs and this thing because it interferes in your system, is that a kind of a disadvantage in some situations?
Well, as far as addressing the first question, I don't think SGRT will completely replace IGRT as far as image-based technologies because they address different problems. Like I said, IGRT is a technology that moves the patient as a rigid body. There's no IGRT currently on the market that addresses a patient, as a moving, independently motion-based creature. So SGRT kind of bridges that gap for IGRT. But what IGRT is actually giving you is an internal reference to your target. And so as long as radiation oncology has targets like prostates that are heavily dependent on bladder filling, rectal prep, those types of things, physiological changes, or they have tumors that move in a complex correlated manner to the external surface like lung SBRT, I don't see it replacing IGRT in that aspect. And in fact, most SGRT systems will say that the standard ground truth is always IGRT. While it is the ground truth, I don't believe it is the standalone way of positioning patients. And SGRT is addressing those limitations that IGRT has, whereas IGRT addresses some of the limitations that SGRT has. So I think they're very complementing technologies, and so I don't think one will ever replace the other. The second question, as far as immobilization, we do use the ORFET AIO solution, which is essentially a mobilization system that allows you to mask a patient from eyes to thighs, essentially from the top of the head to the mid-thigh region. It doesn't replace immobilization, I would say. It does address the times when patients cannot sustain immobilization. We have lots of patients who are either mentally handicapped, demented, where immobilization is just too much for them to handle. In that case, SGRT is a very gentle way of making those patients candidates for treatments that they typically weren't going to be candidates for. And so it allows us to treat a wide variety of patients that have challenges with immobilization. It also allows you to immobilize in a more effective manner. You're not just rigidly clamping them down to a table, but you're trying to immobilize in an effective way, but also in a way that kind of maximizes their comfort as well. And you don't have to worry that by maximizing their comfort, you're suboptimally immobilizing them, because now you're watching them with SGRT. So again, I think having an SGRT system or an immobilization system that complements SGRT is very important. Some people really like the BodyFix system, which has the cellophane and the Vaclock bag and all of that. I think that's a challenge for SGRT because you're covering essentially the entire surface of the patient in a non-reproducible way sometimes from day to day. And there's other immobilization systems that, like the Civco systems that have the gates that go across the patient for abdominal compression and all that, where you're obstructing the surface. Those are really non-complementing immobilization system. I think the Orphan AIO solution, of all the ones I've used between Civco, Bionics, Q-Fix and all of that, I find that the Orphan one is the most complementary to surface guidance, because the arrangement of the masks along the surface of the patient always allows you to essentially give an open area that you can monitor with SGRT. And so it's really important for the physics team to really evaluate not just, I'm bringing in an SGRT system, but how is that SGRT system affected by my immobilization, by my treatment machine. Obviously, if you have a tomotherapy, it's a very challenging geometry for SGRT because you're basically occluding the patient while they're in the board. And so there's a lot of other aspects to SGRT